Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk behind the OR.
Good morning. Welcome to Behind the OR, the Peter Surgical Podcast channel. We are here today with Dr. Diab. Hello, Dr. Diab.
Hello, Laurette. Thank you for having me again.
Thank you for coming. We are here today to speak about minimal invasive coronary artery bypass grafting, and this is our third episode together. Do not hesitate to go to Behind the OR to listen to the two first episodes based firstly on patient selection and on technical aspects of minimal invasive CABG procedures. So today we will be focused more on you, Dr. Diab. So firstly, can you introduce yourself?
I'm Mahmoud Diab, Chief of Cardiac Surgery Department in Rotenburg and the Folder.
So as I said today, the objective is to know more things about you. How do you perform your procedures? What is your habits in operating room, environment, etc.? So firstly, what are your basics when you go to your operating room?
Okay, so I go in the OR, I grade everyone, and then I check the X-ray and coronary angiography again. I look every time before I operate, I look again in the OR, the coronary angiography. So I check the echocardiography with the anesthetist, and then we do some team time out. What are the plan in what are we going to do in this patient? Are there any specific aspects to mention during this team time out? And then we start the procedure.
So you work always with the same team?
Not always with the same team because, you know, they are after a night shift. Some people are absent. So almost every time a new team. But everyone in our department knows this technique very well. So it doesn't make a big difference.
And how is the environment of your OR? Are you listening music? You ask people to be quiet? How do you work?
Actually, I used to listen to music in the other hospital I was working in. But as I changed the hospital, I realized we don't listen to music. But I don't ask anyone to play music or to stop the music, because when I'm operating, even if the music is running, I don't hear it. I'm totally concentrated. But we talk sometimes, and we tell jokes, we laugh in the operating room. But at certain steps from of the OP, I don't talk. I just concentrate on the operation.
And what is your favorite instrumentation? What is your favorite device during your procedures? The best one? I
like the mammaria spreader, because the retractor, because it allows me to see the mammaria very well. I tried several one, and then now I found the best one I'm using. I like it. I like also the subcutaneous stabilizer. So it's and I hope that I would like the 3D camera, the same as these instruments, and in the future robotic.
Thank you for the transition. This is my next question. So, according to you, what is the future of cardiac surgery, of minimal invasive approach?
Yeah, as I mentioned, robotic is the future.
Yeah.
Some centers in Germany use it to harvest the mammary, but they are not allowed to perform the anastomosis with robotic. But I think one day it will be the best way to do it. Some centers use 3D or 2D camera to endoscope to harvest the mammary, but still the anastomosis is done with direct vision.
Okay.
But as I mentioned, I tried the 3D camera in order to show the audience what we are doing. And I have a lock on the camera. You see much better when you look through the camera, through the 3D glasses, than in direct vision, through direct vision.
So that means that it helps you a lot during your procedures to have that kind of tool.
Yes. Yeah.
Okay. And you mentioned the robots. This is something that you already tried in the past, or?
I've never tried it. I've seen it in presentations and
Okay.
and videos, but I will be willing very much to try it.
Okay, I can imagine. And according to you, what are the key to success in minimal invasive surgery?
Proper selection of patient is very important.
Okay.
And then we have to consider that the patient is coming to the hospital to get bypasses that last. So the quality of the anastomosis should not be affected with this approach. And every surgeon should be honest with himself. And in very few cases, when I noticed it was difficult, I was satisfied, but it was difficult. I did angiography after the operation to check that everything is okay. So we should not let the patient leave the hospital with the suspect of unproper anastomosis or bypass. So patient selection, we said, and then the quality of the anastomosis. At the beginning, one should try Lima to LAD only. And it's also, I think, the only graft that has prognostic effect is the left mammary, the left internal mammary to the LAD. This is the gold standard of CABG. So if it is difficult, if you not, it's difficult to do other territories, so we can do this hybrid concept or hybrid approach. We target the left anterior descending with the mammary, and then the other vessels can be interventionally with PCI targeted. There is a selection criteria for such patients. We can talk about it in another episode, but we have to keep it in mind, this concept.
So according to you, it's one of the most important aspects when you want to perform minimal invasive surgery. The patient selection is one of the most important criteria. Okay. Yeah. And do you have an advice for young surgeon or experts who want to develop, who want to start minimal invasive surgery?
As I mentioned before, one should start with off pump through sternotomy, and then minimal invasive. Practice, workshops,
trainings, you mean?
Training, simulator, before we start minimally invasive CABG, and to have a low threshold to go on pump if something happened. So that's why I insert 2 sheaths in the femoral artery and vein to be prepared for the worst scenario. So cannulas have to be in the OR. The perfusionist is in OR and prepared with his cardiopulmonary bypass. And if anything wrong happen, so immediately on pump and then proceed normally with the operation through minimally invasive or convert to sternotomy.
Thank you. It was our third episode together. Before saying goodbye, do you have a last word to conclude this session today?
Safety of the patient and the quality of the anastomosis are the most important in this technique. Thank you.
Thank you for coming, Dr. Diab. Thank you everyone for listening, and see you in next episode.
Thank you. You're welcome. Bye.